Welcome everyone to another JPN Grand Rounds. Today we are joined by none other than the Rabbi Dr. Shlomo Brody, who will be discussing MAiD, medical aid in dying. Rabbi Brody is the executive director of Ematai, an organization dedicated to helping Jews navigate dilemmas regarding aging, end-of-life treatment, and organ donation. For our viewers not familiar with his work, Rabbi Brody is a prolific author whose writings have been cited by Israeli Supreme Court decisions and have been appeared in dozens of publications. His first book received the National Jewish Book Award, and his second book, Ethics of Our Fighters for the 21st Century, has recently been released, and I recommend everyone take a look. All right, Brody, thank you so much for joining us today. And I want to thank Ematai as a whole for not only working on this talk, but helping arrange for our other Grand Round talks as well. You and your team have really made for an excellent collaboration, and we really appreciate it.
Thank you so much. It's great to be together. And thank you to JPN for all the collaborative work and all the wonderful work that you're doing. And it's just wonderful to learn together today. So we're going to be speaking about a very important and sensitive issue, a difficult issue in many ways, which relates to what is now known as medical assistance in dying, MAiD, MAiD. Once upon a time, which is sort of I shouldn't say once upon a time, but is a way in which is now referred to the concepts of both euthanasia and physician-assisted suicide. There's a lot of, I don't want to say politics, but there's a lot of symbolism in the semantics that are used. There was a very interesting New York Times article a couple of years ago, and then recently as well, about how the marketing of what used to be known as euthanasia into medical assistance in dying was part of the ways in which it's sort of helped it grow in its acceptance, which is interesting in its own right, but not our conversation today. And depending on where you are, what location you're in, what country you're in, it can have different connotations. MAiD is legal in the United States in 10 states, along with Washington, D.C. And there it refers to physician-assisted suicide, which means that the physician is legally allowed to provide the pills or injections that will allow a person to take their own life, but the physician himself doesn't administer the drugs, which is interesting in its own right also, by the way, because there are many times when the patient chooses not to use the drugs, precisely because it's a different level of engagement there. In fact, it's in some places, the majority of the times where even when someone has filled the prescription or received the prescription, they don't actually go through with it. In places like Canada and a few countries in Europe, MAiD refers to not just physician-assisted suicide, but physician-administered death or euthanasia. And this is particularly prominent in Canada right now. Canada has legalized both of them, but in the vast majority of cases, what's being done is euthanasia. And I want to start with a Canadian example because I think it highlights how real of an issue this is or how prevalent of an option this is. I actually was in Toronto a couple of months ago and I spent a lot of time with the Jewish community and other faith communities speaking about this issue. It's a very, very serious issue in the eyes of many, and a heated political debate right now as well. And I'll explain to you why. So here's the current state of the law in Canada. Canada, you have to be, in order to request MAiD, it can't be requested by someone else, right? So if someone is in a vegetative state, some family member can't request this. It has to be something which a person voluntarily requests on their own. They have to be over 18, although this is a matter of discussion, whether that age is going to be lowered. That's a matter of debate right now, one of the debates in Canada. They have to have the capacity to make healthcare decisions and provide informed consent. They have to be Canadian, right? Or they have to be eligible for Canadian healthcare services. And here's a key change that happened. MAiD was legalized in 2016 by Supreme Court order in a case known as Carter v. Canada, but it was then brought to the Parliament. But originally, it was only when death was reasonably foreseeable. In 2021, this was extended to also be cases in which there is a grievous and irremediable medical condition. which means serious and incurable advanced state of irreversible decline and enduring physical or psychological suffering, but death does not need to be reasonably foreseeable. Now, it was supposed to be in March 2023 that this would be included also cases where the sole underlying medical condition was a mental illness. That was delayed to March 2024. And now it seems like it's about to be delayed as well because of lobbying by many, particularly in the mental health profession, who think that the law is not set up and the situation is not proper. Ematai actually submitted a brief on this issue to try to get this delayed. And it seems that actually the lobbying here worked and this has been delayed, but it hasn't been official yet. What has this ended up resulting in? What are the numbers like? So here are your numbers. And if you look in 2022, you will see that over 13,000 people in 2022 died through medical assistance in dying. That's over 4.1, I think it's approximately 4.1% of all deaths, particularly prominent in Quebec and British Columbia. In Quebec, 6.6% of all deaths happen through medical assistance in dying. And so you can see how the numbers have clearly jumped over the last several years. And the expectation is that the more and more it gets prominent, more and more practitioners willing to perform it, that the numbers are only going to grow. And with some estimating, they'll get to a point of at least 10% of deaths happening through medical assistance in dying. Now, you can see here as well, this is a general percentage. You can see that the vast majority of cases, 81%, of requests resulted in MAiD, but not always, right? Not always. There are cases when people die beforehand, the cases that people were considered ineligible, and there are cases where the requests have been withdrawn. But in 81.4% of the cases where requests were made, MADE, MAiD was performed. And it's interesting to see that there's a little bit of a pushback right now on this issue politically in Canada. And it's always been from the right, from conservatives, but also from the left now, particularly because there are many who are concerned that underprivileged or people with disabilities or people from various different underprivileged groups are more likely to get MAiD, and those don't have proper health care are going to get MAiD, don't have access to all sorts of types of medical care. And so it's become in some ways an issue on the left, political left as well, that this has gone too far. But by and large, Canadians remain supportive of medical assistance in dying. As you can see here, even with the 2021 criteria where it doesn't have to be, death doesn't have to be reasonably foreseeable, you can see that there is a significant amount of support, although there has been a lot of pushback with regard to the mental illness condition, and that's pushed back a lot as well. But you can see also that, not surprisingly, it's somewhat dependent on person's faith. So in general, people who are not religious are generally much more supportive. People who are religiously committed are much less likely to be supportive, but the rest of the country is particularly supportive of it. And that, of course, is going to be part of our conversation today with regard to dealing with those who are religiously committed and against. Right? Of course, there are people that are against it who are religiously committed, as you can see here, right? But even those who aren't, or who are religiously committed, have to deal with this question about how to deal with a society in which this is going on. Now, it's very interesting to see that some people are very concerned that in Canada, this has cheapened the value of human life. And you can see once again, there's a bit of a religious versus non-religious divide over this issue. But what's particularly interesting to me is that even though the majority of Canadians support MAiD, a majority of them also agree that they are worried that MAiD will be a replacement for adequate social services in Canada, which means you have this really interesting situation where a majority of people might say that they're supportive of a policy, but they're also very concerned that MAiD is going to become a replacement for proper end-of-life care treatments. And particularly, let's think about this. If the MAiD gets extended to be allowing in cases where the sole underlying condition is just mental illness. So you'll have a situation where a person might have a really difficult mental health situation, but something which could take time and could be treated and can be dealt with by a psychiatrist, or a psychologist, or combination of the two, whatever it might be, and they don't have access to it right away because it takes time. As we all know, there's a shortage of healthcare providers, and it takes time. And so you can have this situation where someone will be offered and say, well, we can get you MAiD in a month. You can see a psychologist in 3 months or 6 months, and you can understand why Canadians are concerned that social services are going to be replaced by MAiD. So this is a major issue. And like I said beforehand, there's been pushback on the mental health criteria, and there's been pushback both on the right and even now on the left as well, political left as well, with regard to this issue. But nonetheless, the law as it stands is certainly where it is. It's legal, and I don't see that changing right now too quickly. Meaning, whether you agree or not, I'm just giving a political analysis for our purposes right now, is that most people, most people, when I talk to, when you do political analysis of what people think of the situation, the vast majority of people don't see this being a big pullback of the law. And this raises the question, of course, of a religious perspective on the utilization of MAiD in general. And then, of course, when regards to the issue of how religious people or other people who are conscientiously object, right, against medical assistance in dying, what they can or should do in such a situation, because this is also an area of great concern. The law in Canada is that a person who objects to medical assistance in dying, a healthcare provider, doesn't have to themselves administer medical assistance in dying, but has to provide what is known as effective referral. That means you have to refer to someone who requests such services. You have to refer to them in an effective manner to someone who will provide that service to them. And this raises a lot of concern by some people, not everyone, but some people who are against medical assistance in dying, who feel that they don't want any part of it whatsoever. By the way, it's interesting to compare. In many states in Australia, there also have medical assistance in dying, but there you do not have the requirement of effective referral. Meaning it's not a given that just because you legalize something means that you have to have effective referral for it. But in Canada, there is effective referral. And then the question becomes is, well, what do we people think about religious people, but not only, but as we saw, it's predominantly, but not only religious people who are objecting right now to medical assistance in dying. What is it that they should be expected to do? So it's interesting. There's a lot of very good surveys on this issue. And the majority of Canadians think that a religious facility does not need to offer medical assistance in dying. So if you have a religious hospital, or if you have a religious hospice, or whatever it might be, nursing home, the majority seem to think that they are not required, they should be allowed to move to another facility, right? But it doesn't have to be required in their area. Although it's interesting, one area where you see that there's a lot of pushback, which of course has many Jews in it, is Quebec. You see here that 35% of people in Quebec think that the religious facility is required to offer MAiD, which is pretty remarkable. But in any case, that's with regard to religious facilities. But when it comes to religious doctors, right? So there are a majority of Canadians believe that doctors don't have to participate in medical assistance in dying, but they should be required to refer the person, right, to help the person who wants MAiD. Whereas the 70, as you see, it's between 65, depends on the place, 70% total, right? And on the left here, think that the religious doctors are required to refer the patient to a doctor who will assist them. And this, of course, raises all the dilemmas that we saw. So this is the situation in Canada. It's certainly not as prominent in other places in the states where it is allowed, the U.S. But I'd say that the model of Canada is being looked at. And in fact, when we announced this lecture topic on Ematai and the JPN. So I already got a few emails from people telling me that in their ethics board or their state or whatnot, this issue is coming up. Ematai submitted a brief to the New York State Bar, the legal bar, which is having a whole discussion about it right now on this issue. And it's a growing conversation in the UK and elsewhere, raising the question of a Jewish perspective on this issue. And I admit that, we live in, I want to frame this for a moment, is that we live in pluralistic societies. And there is always this question, of course, of, well, maybe it pays to live and let live, and it's probably not the right example, use terminology here, but you might say, even say live and let die, right? And the respect that we should respect different people's views, but you have grave moral issues that are at stake here. And also you have the involvement of religious practitioners who might object to this. And that raises some of the broader issues that we're going to be speaking about. So I want to first take a look at some of the traditional halachic sources on this issue, and then get into some of the questions of effective referral. So the Gemara, based on the psukim in Noach, from which we learn the Shiva Mitzvah in Noach, derive a prohibition. This is Gemara in Bava Kama, Daf Tzadik Aleph, which tells us, from here, we learn this idea that you're liable for not just killing someone else, as the pasuk seems to imply, but also for taking your own life, for that matter, for wounding yourself, but certainly for taking your own life. And this is included, shvichut damim, in the Shiva Mitzvot B'nai Noah. So as a general rule, the idea of death by suicide or suicide is prohibited in Jewish law according to Jews and non-Jews, for Jews and non-Jews alike. Now, it's very interesting. If you look at one of the late commentators on the Torah, Tzvi Mecklenburg, in his Kav Kabbalah, he makes a very interesting statement on this verse, in which he says, listen, the prohibition of murder is true whether it's l'ra'at hanirtzach, it's for the bad of the victim, whether you want to have revenge against them or steal from them, whatnot. And it's true also im letovat hanirtzach, kishu mishuka b'tzar gadol v'yivacher mavet me'achayim, when a person would prefer death over life because of their suffering. In other words, he's trying to emphasize here is that even when you think this is a beneficent killing, this is a type of killing in which you are coming here in order to help the person, to remove them from the misery, nonetheless, right? Whether you're doing it because you love them, because you hate them, either way, this is a prohibition. And I think this is certainly true, that this is a prohibition, and applying, and here, I think it's important to see the statement, which is brought down in various Talmudic sources. And I think it's a beautiful analogy, which talks about the person who's in the death throes, the goses, who's treated as being alive for legal purposes. So we'll get into this right now. And then we're told in Smachot, in the Mishnah Dalet here, right, that one person should not close the eyes of a person, should not touch them. This person can be shovech damim. And the mashal here is very powerful. The mashal says, Rabbi Meir says, it's like a lamp which is dripping, or a lamp that is going out. Chazal is telling us all human beings are alike. And even if this candle is flickering, we shouldn't be the ones who extinguish the candle. We shouldn't put it out. And the Aruch HaShulchan has a very interesting formulation of this. He says, we're willing to recognize the fact that there might be times when death is preferable to life, which is an interesting statement in its own right. It's a different shir about notions of quality of life in Jewish law. Right? Nonetheless, we should not, it's forbidden for us to hasten the person's death, to bring it about faster, because the world belongs to God. In other words, there is a very strong statement here. It's partly theological, partly moral, which is stating that Jews should not be the ones to extinguish the candle of light. I think it's a very powerful analogy. And I think it's important to recognize the fact that all human beings are seen as alike. Now, I stress this what I'm about to say to you right now, because a lot of times when I hear religious people speaking about MAiD, the response is sort of like, Usser, Gewalt, right? This is terrible, and whatnot. And I think it's crucially important to recognize the fact that you have to have an alternative. Meaning, the reason why medical assistance in dying has become so prominent and is spreading is because medicine can keep people alive for a long time now, but not necessarily in a good shape, including many times of suffering. And you have to have an alternative of how to address those issues. And I'm stressing this because if you're saying that this is wrong, this is bad, but don't also say that we have to take the pain and suffering of people very seriously. So then I don't think you're being serious in part of the ethical and broader conversation. And so I want to stress this point, which here I bring a quote from Rabbi Avram Steinberg, Dr. Professor Avram Steinberg, spoke in the last grand rounds, who made the point of saying that pain, treatment, right? Addressing person's pain and suffering is a halachic imperative, and that treatment should be administered for the purpose of alleviating pain. There's intent here is critical, but it's not in order to hasten the patient's death. Right? And so even if you're going to have morphine or others in which there might be a concern, as an aside, by the way, many palliative care doctors will tell me that properly administered morphine or other types of drugs is not what's going to hasten someone's death, right? When done at proper doses and a careful amount of level, this is what Professor Steinberg is referring to. But even if you are concerned that this is a possibility, that is still permissible because of that goal here is to alleviate pain. And this comes from one of the great proponents that every moment of life is of infinite value, of Eliezer Waldenberg, who also stressed this idea. It's Eliezer, who stresses this idea that even if we're talking about a case of great pain and you're concerned this might shorten life, has the potential, nonetheless, this is still permissible because treating pain is very important. And I want to even go stress this even further, that there's a notion of palliative sedation. Palliative sedation is a situation when a person is very much towards the end of life, and you're administering pain medication in order to sedate the person, meaning the person is aware, you're administering the sedation, understanding that you are going to remove their awareness to relieve them from their pain. And at some point in that process, as it goes along, the person will die, right? You're not hastening this per se, but you are putting them, bringing from a state of awareness to a state of non-awareness, you're sedating them. And both Rabbi Bleich and Rabbi Tendler and Rabbi Halpern here say not only is this permissible, but it's mandatory because the intent here is a matter of reducing, removing pain, right? And that is a very serious issue. And I want to explain this distinction. When you're doing palliative sedation, this is different from euthanasia. In cases of euthanasia, the deliberate termination of the life of a patient by active intervention at the request of the patient, which of course could happen 6 months before you think they die, 12 months before they die, or much earlier even. When it comes to palliative sedation, we're talking about here at a much later state, and the intent is to provide symptom relief, not expressly to end the life of the patient. The proportionality, of course, is very important here because you're going to do it just enough in order to relieve the symptom. And the criteria for success here is based on patient comfort, is not defined by the death of the patient. And so I think palliative sedation is something which is certainly permissible towards the end of a person's life. But euthanasia, which of course can be done at a much earlier stage, is not permissible. And while I admit that distinction based on intent is important, I think it's a very important distinction. I think it's very important that we're not being the person who is extinguishing the candle, right? We're not being the person who is putting out the flickering light. And I remember when I was speaking to people about palliative sedation, various healthcare professionals who were talking about this option, and I said to them, listen, what is it that's so attractive about euthanasia, that people will want euthanasia as opposed to palliative sedation? And of course, there are different types of medical conditions where that might come up, but the biggest issue that's attractive to people about euthanasia is the element of control, right? The element of saying that if you're worried that you're going to be at a point where you can't control the pain, or if you're worried with part of life where you don't really want to be living, you have that power over the situation. You have the autonomy to decide what you will happen there, which I think is precisely what the Aruch HaShulchan is referring to, and saying that in Jewish thought, there are some things which humans should not have control over, including this idea of being the one who's going to put out the candle. And so I think it's important, though, to understand where this came from in the West, and because of this idea of autonomy and the opposition which emerged from it. So I want to go back to the case, to the Canadian example here. It's a very prominent one, a good one. And this is the case that the Supreme Court of Canada declared in 2015, which is what pushed the Canadian Parliament to ultimately pass the law of medical assistance in dying. And the argument that was made in the Supreme Court decision in Carter was based on autonomy and liberty. The rights to liberty and security of the person, which deal with concerns about autonomy and quality of life, are also engaged in individuals' response to a grievous and irremediable medical condition, is a matter critical to their dignity and autonomy. The prohibition denies, I mean, the legal prohibition of the state denies people in this situation the right to make decisions concerning their bodily integrity and medical care, and thus trenches on their liberty. And by leaving them to endure intolerable suffering, it impinges on their security of the person. In other words, part of the big response, motivation of the Supreme Court argument here was the phenomenon of saying that, well, this relates to visions of the good life and what life should be all about. And that being the case, the right of liberty gives a person the right to die. I think someone's doodling here, if we can get remove that on here. Now, this is not the first time that this issue came up. And already when it was physician-assisted suicide, it was being discussed in the United States, there was big cases in Oregon and elsewhere in Washington State. And there is a very, very interesting brief that was submitted to the court by a number of very, very significant philosophers: Ronald Dworkin, Thomas Nagel, Bob Nozick, John Rawls, J.J. Thompson, and Thomas Scanlon. And the six of them, who come from different worldviews to certain respects, certain issues, wrote a brief on this issue. And it was later published in the New York Review of Books, in which they made the argument of saying that the Constitution forbids government to impose such convictions on its citizens. The issue of what should be done and what people should have done to them when they are terminally ill and in pain is a matter of religious or ethical conviction on which the state needs to be neutral. And so they think that this goes against the Constitution. There's a constitutional right for people to make decisions about such matters involving the most intimate and personal choices a person may make in a lifetime, relating to personal dignity and autonomy. And not surprisingly, they're quoting Planned Parenthood versus Casey, which was the 1992 case that affirmed Roe v. Wade, meaning part of the argument here is that if you think that a woman has a right to do with her body as she chooses, even though that impacts the fetus, so too should a person have the right to die. And that's a matter when they're in such a situation. And they make another argument here, which says, listen, we already allow us to withdraw care. So what's really the big difference between withdrawing care, which you know will end up leading to that result, as opposed to just hastening death, which is doing what the patient wants, and this is quicker and this is more humane. So if that is the case, that you can withdraw, we shouldn't use the term care, withdraw intervention, so too you can hasten death right? Why is that something which the physician cannot provide for the person? And if you look on the right, they say, listen, they understand that a doctor turns off a respirator in accordance with the patient's request. Right? The intent here is the same, to help the patient die. And the only difference here is that patients can't turn off the life-supporting machinery. Right? When it comes to physician-assisted suicide, they need then a doctor to help them out here. And the right is to one of a help of a willing doctor. In other words, part of the argument of the philosophers is to say that we need to have a situation in which you're not forcing healthcare providers to do this. You're just trying to make sure that if you have a willing doctor, it is legal for the willing doctor to help the person do this. And so that's a very powerful and strong argument in the name of liberty, which basically says if you got a willing doctor and if you've got a patient who wills this, this is a matter of liberty, no harm done. And if no harm done, right, at least you might say it's harmful, you might think it's against it, right? But that is a matter of philosophy and ethics and religious conviction. That should be up to the person. And when they wrote this philosopher's brief, there was a lot of pushback on this issue. And one of them was by another prominent philosopher, a legal philosopher named George Fletcher. Fletcher is an expert in criminal law, which of course was the issue here about whether it should be criminalized or not. And Fletcher wrote a response and said, if the courts or a conscious patient insist the physicians cease treatment, death is merely a contingent consequence. But if medical professionals are ordered to participate in killing by supplying a deadly dosage or working-style gas mask, many of them would sense a corruption of the medical mission to save life. In other words, part of the argument that Fletcher makes and many others make is to say that this itself is a distortion of what healthcare is meant to be about. The whole medical profession is not meant to be about this. And another person who made a similar type of argument is a different philosopher named Leon Kass. Leon is actually a Jew of now a very traditional affiliation. Actually lives in Yerushalayim now. And Leon, Professor Kass, wrote a number of essays on this issue, in which part and parcel of his argument is to say there's a very big difference between withdrawing care and actively killing someone. When you withdraw interventions, when you pull back, ceasing a medical intervention, you're allowing nature to take its course. Not the physician, but the underlying fatal illness becomes the true cause of death. Right? In this situation, that is very different from a case in which you actively cause the patient to die. And he felt, as both a matter of law and as a matter of medical ethics, the right to refuse unwanted medical intervention is properly seen not as part of the right to become dead, but rather as part of the right protecting how we choose to live even while we are dying. Meaning we have the right to choose how we want to live to the end, including whether we want aggressive interventions to be done or not. This is something very different. And he's concerned not only in the fundamental element of the problematic of the law, but also about how this is going to transform healthcare. Because he says once we refuse the technical fix, physicians and the rest of us can also rise to the occasion. We can learn to act humanely in the presence of finitude, and more than morphine or removing chemotherapy, the dying need our presence and our encouragement. The treatment of choice is and always will be company and care. Okay, so this is sort of where the philosophical debate is at, where some are very much believe this is a matter of liberty and a matter of principle, and others argue that this is fundamentally a wrong act. You're killing someone. They fundamentally think it's a distortion of the healthcare profession. They fundamentally are concerned that it's going to distort social services and the entire way that people approach those who are dying. And there, of course, the slippery slope argument, which we made reference to earlier, which is that at the end of the day, the people who are going to end up being killed faster or dying faster are going to be those who do not have access to proper medical care. And that can be people underprivileged financially or socially, socioeconomically, or in other ways, or they're alone. This is a big issue. where people who, in some situations, if they had a big family support network, or other support network, would be able to live with this illness, but people who are alone, which is a major issue in Western societies now, don't feel they have this option to stay on because they don't feel they have the support network in order to stay alive. So this is sort of where the debate is at right now. And the question, that comes up is, can you, even of the proponents of MAiD, is whether or not they can provide the proper safeguards to it. And there are many, meaning that all these slippery slope arguments will be true. Opponents of MAiD in Canada believe that the Canadian example shows how all the safeguards have failed, and the rise of medical assistance in dying is a consequence of the fact that it's come to be a substitute for proper palliative care and end-of-life treatment. And in this respect, I think it's important to stress this point because I think some people in the Jewish community think that this is sort of akin to abortion, meaning you might think abortion is acceptable or not acceptable in certain times, whatever it might be, but you'd say it doesn't really impact other people. So why does this matter so much? But I think the response to that is that the whole culture of end-of-life care is getting transformed precisely right now because of the phenomenon of medical assistance in dying becoming much more prominent. That's certainly part of the argument that's being made right now in Canada, and that is part of the concern here. Beyond that issue, and my own perspective on this, obviously influenced by halacha, but I think also based on my ethical understanding of halacha and the read of the situation, is this is a deep and grave concern. Meaning the fact of medical assistance in dying becoming so spread so far in Canada is indicative of the fact that when it's easier to get medical assistance in dying than it is to get proper treatment of ailments, whether it's mental health or other issues, you're going to encourage people to die earlier on, which of course also includes a financial incentive, right? End-of-life healthcare, particularly if people have significant diseases, is very expensive. And part of the motivation here clearly is an economic factor as well, meaning it's not just to alleviate pain and suffering. I don't want to overemphasize that because I think it's not fair to those who support MAiD because they support it because they think that this is a ethical option that should be given to people to reduce their pain and suffering. But there's no doubt on a systematic level, there's a certain amount of economic incentive to having this option, which then raises the question that if this option exists and you are a person who has conscientiously object to MAiD, but you're being told that not just that that it's going to be legal in your state, but that you as a healthcare provider have to provide effective referral for it, what is it your responsibility to do in such a situation? And this is causing a lot of angst, and not just in elements of the Jewish community, but in elements of the Catholic community and others as well, other people not of faith who are just ethically against medical assistance in dying have this dilemma. So if you take a look at the laws of the requirements in Ontario, here this is an example I give from Ontario, but some other places as well. So you will see that an effective referral involves a physician taking positive action to connect a patient with another physician, healthcare provider, agency. The effective referral must be to a non-objecting physician. I mean, you can't run around loops, right? You have to tell them to someone who you know is going to provide them this in a timely manner, right? And the question that comes up, of course, is this acceptable under Jewish law? Now, it's important to understand that in theory, and I think actually in practice, certainly outside of the hospital situation, right? But effective referral doesn't mean it's not synonymous with direct referral. This was a statement of the college, the president of the College of Physicians and Surgeons of Ontario in 2018, where part of his argument is to say that you're sending them on to the person who can help them. It does not guarantee a specific outcome for the patient. I mean, we saw earlier, it's not exactly guaranteed. In practice, so we saw this earlier, where was this? It was about 80%. right? That we saw that effective. So it's a pretty effective referral. Let me just go back to where that was. Make sure I got the number right. Yeah, that the outcomes are about 80% that of requests that end up with MAiD, but it's not, there are cases where requests are withdrawn or requests are deemed ineligible or the person dies from a cause other than MAiD, which happens, as you can imagine, because people are significantly ill many times when they are requesting it. So it's important to know that effective referral is not direct referral. It doesn't mean you're going directly to it. In a hospital context, it's a little bit more complex because in the hospital context, frequently it happens much faster and the opportunity for it is much faster. But even there as well, there are times when people are deemed ineligible or it doesn't happen right away or they die from something else. And the question becomes about halachic participation on this issue. So in general, in Jewish law, there's something called lifnei iver, which teaches us that you cannot facilitate someone else committing a sin. This includes, by the way, facilitating a non-Jew as well from doing sins under the Shiva Mitzvahs B'nai Noach. That's actually one of the classic examples. You cannot hand a Noahide a severed limb from a living animal, Ever Menachai. That is a violation of Lifnei Iver, Lo Titen Michshol. But Lifnei Iver of the two sides has to be a case where they need you in order to do this sin because they're on the other side of the river, so to speak. If it's only on one side of the river, it's not exactly clear, but it seems from the Ramah as well as the Shach that with regard to a Jew aiding and abetting someone on the same side of the river, meaning they could do it themselves, they don't need you to get it done. Right? Is this a violation of Lifnei Iver or Misayea? And the answer seems to be, the majority seem to conclude, that that is not a violation even of Misayea, what I call aiding and abetting. Now, this doesn't help the Jewish patient, healthcare practitioner in cases where the patient they know is Jewish. Right? So, if someone comes in and their name is Reuben Cohen, and you talk to them and you recognize them as Jews, right? So you still run into issues here of aiding and abetting, although it might not apply as well to persons of Jewish faith who aren't committed to Jewish law in any respect, which may or may not help you depending on how you think about this. Because I want to give an analogy to a case. Should Jews, I come from originally was born in Texas, born and raised in Texas, should Jews own gun shops? And think about it for a moment. You might say, well, let's say, you could say, well, sometimes people buy guns for self-defense or for other purposes, are fine. But let's say you are highly suspect that someone's going to use this gun in an illicit manner. Should you sell it to them? Well, you could argue and say, listen, maybe they're going to kill someone with it, but if they don't get the gun from me, they can get it from someone else. You could make such an argument, and indeed there is such an argument that sometimes is given. I bring here the Av Bezdin Yerushalayim, who wrote a tshuva on this topic, where it says, listen, a Jew can own a gun store because if they don't buy it from you, they'll buy it from someone else. But I like to quote the open letter that Rabbi J. David Bleich wrote to the owner of the pawn shop in Dallas, Texas, which sold the gun that was used in the assassination attempt of President Reagan. And the pawn shop owner was Jewish. And Rabbi Bleich wrote an open letter to him and said, listen, Jewish law recognizes that the indiscriminate sale of weapons cannot fail to endanger the public. Jews ought to be in the vanguard of those seeking to impress upon legislators that handguns are indeed stumbling blocks, which must not fall into the hands of the blind. Criminals do commit crimes, and it's precisely because the morally blind criminals are exposed to crime that Judaism teaches us forbidden to provide them with the tools of the trade. In other words, some say it's the gun, right? It's not the guns that commit the crimes, it's the criminals who commit the crimes. Right? Blaich's response to that is, yes, I get it. So you're not supposed to be giving them, right, the tools of their trade. And the fact that they can buy it somewhere else doesn't mean you should be involved in this profession. So that raises the issue. Well, how far would you go? Because if you really feel that medical assistance to dying is a really grave sin, should you be then telling healthcare professionals they shouldn't be in this profession anymore? I mean, think about the implications of this. right? That's a big deal to make such a statement. And so there is a bit of an attempt to say, listen, this is not exactly a case of aiding and abetting for a number of different reasons. And you can give a number of arguments. For example, I'm not getting into all the details here about Lifnei Iver Messiah, but let's keep in mind, it's not always clear that just because, let's say, you refer someone to the agency that will administer MAiD, so it's a chain of reactions here. Maybe they'll go through with MAiD, maybe they won't. Maybe they'll even make the phone call. How do you know if they're calling or giving the phone number? How do you know they're going to reach someone so quickly? How do you go through with it, right? It's not exactly a real direct form of aiding and abetting. Excuse me. And then you also have another question besides the timing factor, right? How far do you go? Do you say a person has to give up their profession? Right? Keep in mind, you could lose your license if you don't do effective referral. Do you think a person has to give up their profession in order to prevent someone else from doing something which they could do anyway without you? Because if you won't do effective referral, they'll find it from a different doctor or they'll find it on the internet. Right? There are many different arguments here. Or, as we mentioned earlier, maybe the prohibition won't happen at all. So you can make a number of arguments for why this could be permissible. And the question becomes is, do you want to make such an argument? So it's interesting. In the cases of an illicit abortion, we're not talking about abortion today. There are certainly times when halacha permits or might even mandate abortion, but there are times when it would be prohibited according to all opinions. And the question would become, are you allowed to be a healthcare provider who participates in this? So if you're going to be the actual person performing the abortion, that would be clearly prohibited because it's you doing it. You're not just aiding and abetting or facilitating, you're doing it. But what about, could you be the anesthesiologist or the ultrasound technician who's giving over the information that will then be used to make the decision and then go about and lead to the abortion? So it's interesting, Rav Shlomo Zalman Auerbach and Rav Yoshev both paskin that the ultrasound technician is not a problem. You don't have to give your job there. It's too distant away. But the anesthesiologist is too directly involved. That would be a problematic position to hold. Rav Eliezer Waldenberg disagreed and said even the anesthesiologist is not performing the act, and the act can be done anyway, and you certainly don't have to give up your job for this. And it is very interesting that Rav Asher Weiss, the great posek in Yerushalayim today, was asked this question. It's been published in the tshuva that was published in the book of his Talmud, Rabbi Sprung, from Shari Tzedek. And Rav Asher Weiss does not feel that effective referral violates Misayea. Meaning he thinks it's a terrible phenomenon, but he doesn't think that when push comes to shove, a healthcare provider has to give up their profession, right, in order to fulfill the obligation of effective referral based on the logic that we saw beforehand. Right? He says that, first of all, you're not, he talks about the anesthesiologist case, he agrees with the Tzitz Eliezer on this, and he gives a couple of arguments, but part of the argument is saying that you're not really actually involved in this act. He even thinks that's true for the anesthesiologist, which I think is a bit of a stretch, but that is certainly the case of just doing effective referral, and therefore Rav Asher is of the opinion that effective referral is not a violation of Lifnei Iver or Misayea. When I was in Toronto recently, however, I will tell you that other poskim in that area are not so comfortable with it. And this remains a real area of concern for them. And again, leaving aside the issues of whether technically or not you violate the issues of Lifnei Iver or Misayea, there becomes a much broader question about caring about the needs of the broader society. And here, I always like to quote the Maram Shik. The Maram Shik in the 19th century was talking about related issue if we have to care about the behavior of non-Jews, whether they follow Shiv Mitzvah Noach. And the Maram Shik points out that whatever is going to happen with the non-Jews is going to impact the Jews as well. Meaning behavior that goes on in public is going to be adapted by others, including Jews. And so if you think that, this is something that we can avoid, won't impact the Jewish community, you're wrong. But Beyond that, which I think is certainly true, you talk to rabbis in Toronto, talk to rabbis in Montreal, particularly amongst Jews who are not necessarily Orthodox, but are traditional and affiliated in many ways, they are certainly utilizing MAiD. And it's a cause of great concern to many traditional Orthodox and non-Orthodox rabbis who are very much upset about the phenomenon. And so it's certainly a phenomenon that's impacting the Jewish community. It's impacting, of course, the broader community. And I'll end with the following phenomenon, which is you ask yourself, who are the allies on this issue? So within the Jewish community, as expected here, parts of the broader Jewish community are in support of medical assistance in dying because they believe in autonomy as a great value. In fact, in Toronto, the previous subsequent head of the medical society was a traditional Jew who's become a very big outspoken supporter of medical assistance in dying. And perhaps not surprisingly, those who are much more opposed to it are other people of religious faiths, including the Catholics, who are much more inclined to lobby against this phenomenon. Even though, by the way, the Catholics are more than willing to deal with pain in a very serious way, and including in withdrawing care, but nonetheless, they are concerned about this as well. And perhaps not surprisingly, there's a certain amount of political alliance on this issue between Jews and Catholics alike. So this is sort of an overview of where I think we're at when it comes to medical assistance in dying. I'll be happy to take questions in the chat or beyond it. But my own opinion on this is that I want to stress this. The reason why I chose to speak about this topic is I think this is a really big issue that's going to impact the future of healthcare when it comes to end-of-life care. And we need to be coming up proactively with statements and responses on this. And it shouldn't be just defensive or responsive to what others are doing. It's important for people who are against medical assistance in dying, like myself, to also come up with proposals of how you address the issues of suffering and those who are dying and give a proper form of medical care when it comes to those who are dying. And so I do think it's very important that we have both elements here as well, which of course is something that we at Ematai are very much interested in doing, but that's a conversation for a different time. Mark.
Thank you so much. What an incredible share. We really appreciate your time. I agree, it's such an important topic. We did get a question in the chat. I don't know if you're able to see it or if you want me to just read it to you directly. They wrote, some argue that if abortion is legal, why should assisted death be legal? How do you draw the distinction?
Meaning, if you argue, why shouldn't assisted death be legal?
Yeah.
Right? So in other words, I think, yeah. So I think the argument, Alan, that you're saying is, listen, if we've come as a society to say that liberty should govern these issues, autonomy, because these are deep issues that people of religious and ethical convictions can disagree upon, why should it be any different? So you could be right. I mean, that was part of the argument that was being made in the philosopher's brief. Right? The philosopher's brief basically said that along these lines, exactly what you want to say. Right? If you make an argument based on liberty, it should go all ways. So it's interesting, of course, Roe v. Wade got overturned in the United States. I know too, whether that's a good thing or a bad thing is a matter of different discussion. But there was a bit of pushback on that, of course. And the question was because, so in other words, your proof text might not be right as solid as might be argued, but I think also the real distinction is, in my mind, you could argue this, but let's say a person, abortion is legal. Let's say it's legal in cases of potential fetal disease or Tay-Sachs or whatever other case that might come up. And someone else is offered abortion, they choose not to have the abortion. Will they still get the same type of care for themselves, neonatal care, right, their pregnancy and whatnot? I think the answer has generally been yes, meaning it could be that healthcare providers or others were judgmental of them and felt they made a wrong decision to bring this child to term. But at the end of the day, by and large, people didn't feel that their care that they got when they were during the time of the pregnancy was different. It was understood that some people disagree and they're going to get the same type of care as a patient. The great fear when it comes to end of life care is that you're going to have situations where A, you have to have healthcare providers who are doing stuff that goes against their conscience, but B, that's going to entirely change the way in which end of life care exist in the given society. I think that's a area of great concern right now in Canada and other places, and I think that's been borne out as well. So I think, even when you come within this issue of liberty when it comes to abortion, you might make that distinction between abortion as opposed to end of life care. The sources cited make clear that a third party cannot hasten or aid death. Is there any argument to distinguish whether perhaps the patient themselves is different? Third party cannot help, but one can assist themselves. Ernest, is a great question. Dr. Mandel, it's a great question. You can make such an argument, but I don't think that such an argument is found when it comes to allowing it lechatchila, meaning b'diavad, when we have cases where a person suffering ends up hastening their death or committing suicide. So when push comes to shove, as much as it creates discomfort, we understand that we don't treat the person as MAiD a person has killed themselves, but rather understand that they had a case of onus, that a compulsion that caused them to take their life. When it comes to a third party, however, I don't think that argument can be made. And so you're right. It's an interesting question, but I don't think we have a situation where the sources allow for a person to take their own life in such situations, even though, of course, we understand the suffering that they're going through. Mark, I'm having trouble keeping up the questions.
Sure, yeah.
What's next?
So let's go to Leon. Is your statistic for Canada of outcome MAiD those who receive the prescription or those who use the prescription? In the US, a good percentage of those receiving the prescription don't actually use it, probably because the sense of control provides enough reassurance that they can end their pain if and when they can endure it anymore.
Yeah, the
So
vast majority of cases in Canada aren't a physician-assisted suicide where they provide a prescription, but rather where it's administered. And that's one of the big differences on it. So I would agree that if you have a situation where the state is pushing, there's a lot of political pressure or otherwise, to legalize MAiD, it would be much better to make it physician-assisted suicide than it is to euthanasia, precisely because of that issue. And Desmond, it's a very fascinating phenomenon. You're correct, Desmond, that in case of physician-assisted suicide, many times people don't fill the prescription or don't utilize it. And that power of control is very important.
um, Alan, the one who asked the question about the abortion earlier, drew the conclusion that another distinction that might be made regarding the abortion and what we're talking about here today is that the sick person is a full legal person, whereas a fetus is not a legal person.
Right.
Um,
I think that is an important point. The moral status of a fetus versus a human being, I think, is different. Obviously, there are those who feel that late term or more advanced fetuses are in a different situation and might be closer to human being if they could be viable, right? Whatnot. But I do think could be, that could be part of the argument here as well.
and then lastly, we have Dr. Liman. Is there anyone arguing to make a new field of professionalism? Why should physicians be the ones to prescribe lethal doses?
Yeah, I mean, it's a great question, actually, because you could be arguing here and saying that let's just create a field of this and say this shouldn't be handled by the medical professionals. We should sort of separate it out. In fact, actually, think about it. You could compare it a little bit to situations of organ donation, where the healthcare providers of the patient are not those that are involved in the organ procurement. They're sort of meant to be a bit of a wall and separation of the two. You could make such an argument of that. There is a bit of a specialty, I don't want to say business, but especially developing in Canada where it's become more prominent of people that basically just do this. Right? That's what they do. And maybe that would help a little bit. Although at the end of the day, their training is going to be as of doctors. So I don't know if that would fully help, but maybe that would help a little bit in terms of it. I definitely feel that there would be a certain advantage to that because palliative care doctors in Canada are very concerned that people are not going to go to palliative care doctors or just try to treat dedicated to treating pain because they're afraid that they're going to be offered or pressured to do medical assistance and die. And this is a real issue for oncologists and others as well, but certainly for palliative care specialists who are very much afraid that there's going to build up a serious amount of distrust of their profession by the patients. And there's no doubt that that is an area of concern right now. And so you could argue perhaps that maybe we get to the point, which is Canada is basically at already, where it's become so prominent that there should just be people who do this, and they're called something. They're called MAiD doctors or MAiD practitioners or whatnot. There is a cynical view of this that was offered by a real opponent in the 80s of medical assistance in dying, physician assisted dying, assisted suicide, PAS. He said you should call it PAS, philosopher assisted suicide. And he said if all you philosophers are so in favor of it, you should just go and do it yourselves and leave physicians out of it, right? I understood the point that he was trying to make there. I see Dr. Mandel, similar idea here. What's Dr. Pop suggesting?
I can read it for you, but I'm not entirely sure what
Please.
the uh, argument that if assisted suicide is to be legal, then it should not be part of physician's role has been made part of the ACP position statement, and I believe Dr. Dan Solnasi has as well. I'm
Right.
not.
So yes, Dr. Pop is just pointing out that this idea that Dr. Lib and Dr. Mandel are suggesting might help along the way of saying, let's keep this out of the role of physicians. I just, at the end of the day, though, I mean, I understand where that's coming from, but ultimately this is they call it medical assistance in dying for a reason. So if you're going to say that, it's medically assisted dying, but it's not being done by medical practitioners, maybe that'll help deal with some of the issues from it. But I don't think it really ultimately solves the broader moral issue. Maybe it helps a little bit in terms of effective referral. Maybe it helps in terms of protecting the medical profession per se. Um, you could call them executioners. You call them MAiD practitioners. I mean, you call them a lot of different things. I guess that would help in some ways, but I don't think it deals with the broader societal ethical issues as well.
All right. I think that that's it as far as the questions. Again, Rabbi Brody, thank you so much for your time. Great share, great topic. And we look forward to collaborating with you again.
Likewise, be well.
Take care.